Welcome. This is the invited symposium promoting a culture of prevention in international perspective. My name is Hanno Petras, and I will be chairing this session. Just a little bit of background. This invited symposium is sponsored by the International Committee. The SPR International Committee was established in 2009 and aims to support and encourage global collaboration between prevention researchers and practitioners. And just to make a little pitch for next year, where I hope we can meet in person, the International Committee organizes the International Networking Forum every year, which occurs on the first day of the SPR conference. And it's a great opportunity to interact with prevention scientists who are interested in conducting research in international settings, and its registration is free. So if we're able to meet next year, please think about joining us. A little bit background, and when we conceived this special issue in prevention science, which is kind of the background for this invited symposium, a lot has happened. And you know, the COVID-19 pandemic has really introduced the importance of prevention to the world in quite a dramatic fashion. And it really has made it the focus not only to scientists, but also practitioners, policymakers, and the general public. But as you also are well aware of, preventive recommendations to reduce the virus spread, such as social distancing and wearing face covers, have really exposed major differences among stakeholders, regions, and political beliefs. And these differences center around economic issues, citizen health and well-being, as well as individual freedom versus the common good. When my colleagues, Brenda Miller and Moshe Eshalaveli, and I began working on the special issue, we were motivated by the recognition that thinking and acting prevention is not really a natural state of mind. And this recognition probably could not be more true than today. And we found that it's very striking, given the cumulative efforts made in the field of prevention science over the past 3 decades. So this special issue has been initiated by the will to draw prevention scientists' attention to the question how to foster the emergence of a culture of prevention. When we recognize that the term culture of prevention is not as clearly defined as we wish, but we feel that, or we think that, it relies on several underpinnings, including a public receptive to the ideas and values of prevention, a supportive policy and legal framework, and a plan to coordinate multiple sectors and levels involved. This symposium brings together 3 of the 6 studies to appear in the special issue in prevention science and aim to address some of these questions, including shared and non-shared risk factors for problem behavior, how to refocus systems towards health, and how to measure the extent to which a culture of prevention has been achieved. And now, without further ado, I would like to introduce the first speaker, Dr. Bosco Rowland. He is a senior research fellow in the School of Psychology and the Center for Social, Early and Emotional Development at Deakin University, Australia. And he is also the honorary CEO of Communities That Care, not-for-profit organizations established to build prevention capacity in Australian communities and to improve health and behavioral outcomes at a community level. Bosco, why don't you take it from here?
Thank you, Hanno. Thank you for that introduction. So this study is a collaboration with 4 countries across 3 institutions. So there's myself, Bosco Rowland, Professor John Toombaroo, who's also from Deakin University, and is also partnered with the University of Washington to bring in the USA component. Harry Jonkman from the Werwi Jonker Institute in the Netherlands, and Shri and Renati Solomon from the Institute of Child, Adolescent and Health Research in Mumbai, India. Now, Hanno, do I move the slides or will you move? Thank you. All right. So this presentation is addressing the question, is there cross-national consistency or variation in the structure of problem behaviour and associated influences? Some people might be aware that problem behaviour really came into prominence in the early 50s, but came into the lexicon in the early 50s, and Jesser in 1977 brought it into real prominence when he started to talk about behaviours that cluster among young people and the tendencies for unconventionality and the tendency to violate social and legal norms amongst adolescents. And behaviours that were clustering tended to be things around alcohol, tobacco, illicit drug use and delinquency. To date, most of the research on problem behaviour has been done in the US. However, this study was looking at the extent that there was cross-national consistency in the clustering and the structure of problem behaviour in the USA, Australia, the Netherlands and India. We also examined the consistency of the predictors of problem behaviours across the 4 countries and across 2 time points. So next slide, please. We know from longitudinal studies that behaviours manifest themselves in the adolescent years are predictive of harmful consequences in the later years in life. Next point, a large proportion of the world population are adolescents, about 18%, and the majority of these live in developing nations. So investigating cross-national consistency will not only help with theory development, it will also help with identifying policy and cultural contexts that may need to be considered when adapting prevention programs. So based on the literature, we hypothesised that there would be cross-national differences in the level of predictors and problem behaviour. Problem behaviours would be predicted by gender or males, socioeconomic status and minority status, and then the number of risk factors would predict problem behaviour at time 2. Just stay there, Hanno, don't move anymore. So problem behaviour, as I said, was defined prominently or came into prominence with Jesser, and they comprise of alcohol, tobacco and illicit drug use. So it's argued that these behaviours have common causes and are a product of the person-environment interaction. And while they can be measured individually, there's evidence to suggest that they can cluster and form one construct. Okay, next slide, please. So the study designed for this study was a cross-national comparison of the structure and predictors of problem behaviour over a 1-year period. Data from the USA and Australia were collected in 2002 and 2003, and these samples were designed to be state representative samples for each of the countries. The Netherlands sample was collected in 2008 and 2009 and was part of a randomised controlled trial, and the Indian sample was collected in 2010 and 2011. Surveys in the Netherlands and in India were translated into the official language, in Dutch for the Netherlands and Marathi for the language of Mumbai. The average age across the participants for each nation was approximately 13 to 14 years old. Next slide, please, Hanno. So as I said, they were meant to be straight representative samples. So there was a two-stage cluster design. There was a random selection of schools, and then from the schools, there was a random selection of students. Just press the button again, please, Hanno. Thank you. Next slide. So as you can see, there was a strong sample size in each of the countries. In Australia, we had 1,957. In the US, 1,942. A slightly smaller sample in the Netherlands with 662. And in India, a much larger sample of 3,923. For the surveys, we measured a number of things. And the same survey instrument was used in all 4 countries, the exact same instrument. This was the Communities that Care Youth Survey. It collects information on a variety of health behaviours, alcohol, tobacco, illicit drugs, and that was measured in terms of how often it was consumed in the last 30 days, and that was dichotomised to be ever or never. Violence or antisocial behaviour was measured as beating up someone or threatening someone with a weapon, and that was dichotomised to mean ever or never. Gang involvement, whether a respondent had ever belonged to a gang, and again, dichotomised as never or none. The instrument collects a variety of information on risk protective factors at the peer, individual, family, school and community level. A total of 9 risk factors were measured. For example, parents' attitudes to drugs, academic failure, low neighbourhood attachment. The average number of risk factors was calculated and used as a control variable. Demographic variables such as socioeconomic status and minority status, representing migration or class, such as white background or whether they belong to an upper caste in India, was also assessed. Next slide, please, Hanno. So here's a picture of the overall model which we used M+ and structural equation modeling to analyze. And you can see, just press the button again, please, Hanno. There's the latent variable for problem behavior at wave 1, again, Hanno. The latent variable for problem behavior at time 2, again, Hanno. And then these are the influences that we were saying would predict, we were hypothesizing would predict at wave 1 or wave 2. And you can see from that picture that there are minority, parent education, which was the socioeconomic status, the gender, and the number of risk factors. Next slide, please, Hanno. So I hope you can see that. I'm not particularly big on my screen, but what I'll do is I'll talk you through some of the key things. The first thing we did was we examined whether there was, using confirmatory factor analysis, whether there was a single interrelated construct that could be identified with the binary indicators. Then we did some invariance testing between the 2 time points and between the 2 countries. And then we examined the risk factors as predictors for the 4 nations. Okay, so you can see in the first column there's the total, so it's the complete sample. And then in the second lots of columns, there is the Australian sample, then the USA sample, the Indian sample, and the Netherlands sample. And you can see across the top we see wave 1, and then you can see further down we see wave 2. So wave 1 is the clustering of those problem behavior variables, and then wave 2 is the clustering of the problem behavior variables at wave in the second time points. And then you can also see the fit statistics and the invariance testing at the bottom. So I'll just talk you through some of these, and you can find this in more detail in the article that's published in Prevention Science. But overall, we can see the loadings for the whole sample and for each country. The loadings were significantly different between the time points for Australia and USA, so between wave 1 and wave 2. And we also found some invariance between Australia and USA. The violence and non-violence and belonging to gangs were higher in Australia. However, alcohol, illicit drug use, and binge drinking were higher in the USA. Now, with India and in the Netherlands, there was a little bit of missing data that we had to manage. And so we had to do some imputation in the Indian and Netherlands data. So we couldn't do the invariance testing between the 2 time points or between countries. So what you can see is there are no invariance testing between at the bottom of that table for India and the Netherlands. However, what you can see is that for the Indian sample, cannabis didn't load in time 1, but did load in time 2. In the Netherlands sample, there were very, very low numbers for cannabis, illicit drug use, and binge drinking. And so we couldn't include those in the construct latent variable in time 1 or time 2. And so there were some problems with invariance testing, so we had to leave those out. And that's why you can see some of those gaps there. So that was already, in terms of testing for construct validity, we were seeing differences in terms of the prevalence of behaviours in the Netherlands compared to other countries. Okay, next slide, please, Hanno. So this is the full structural equation modelling, looking at the construct, the latent construct between wave 1 and wave 2, and then the predictors. So again, we can see the columns for the whole sample: USA, India, and the Netherlands. Australia, USA, India, and the Netherlands. We can see the latent variables and the loadings, and we can see the predictors in the bottom half for wave 1 and wave 2. So we can see problem behavior at wave 1 and problem behavior at wave 2, age, parent education, and female. Again, it's a little bit difficult, and I apologise for that table, but it's very hard to put all that information in one table. But I will speak through some of the key findings here. So a mix of variables were predictive of problem behaviour at time 1 for the Australian, USA, and Indian sample. However, inconsistent with our hypothesis, Being male or socioeconomic status was not predictive in each of the nations, and minority status did not predict problem behaviour for any nation. However, we did find out that we did identify that problem behaviour at time 1, consistent with longitudinal studies, predicted problem behaviour at time 2. And the greatest coefficient was in the USA with a 0.9, and the lowest was in India with 0.5. We also identified that risk factors at time 1 was predictive of problem behaviour at time 2. Next slide, please, Hanno. And you can bring all the time points up, the 5 time things. Thanks. So consistent with our hypothesis, we identified that problem behaviour did vary by nation and by time points. We identified loadings and indications were similar in USA and Australia, and we identified that there were similar findings for India at the 2 time points. Next slide, please, Hanno. And you can bring the 4 dot points up. So the differences suggest that problem behaviour, while is universally conceptualised as drug and alcohol and antisocial behaviour, they can manifest differently across the nations. It suggests the need to examine the cultural, policy and program factors that may explain the cross-national differences. And we have identified some of the universal aspects of this development of problem behaviour in adolescence. While the invariance testing could not be done in the Indian and Netherlands data, it's possible. While invariance testing could not be done in the Indian and Australian data, it's possible that similar programs and policies could be relevant in India. So this suggests that we should examine further policies and programs that explain cross-national variance in problem behaviours and prevention internationally. Thank you. Next slide. So you can find these details in the full publication, and of which I've listed there. What I've tried to do is give you a very brief overview of the findings and suggest the cross-national implications for these findings. I hope you have found this of some interest, and you'll look forward and analyse and look more closely into the findings in the publication. Thanks very much, Hanno.
Thank you, Bosco. And I'd like to introduce the next speaker. And actually, can I ask a question to the technicians? Is there somebody there?
Yes.
Hi, I have a question. So when I put the slides on presentation mode, I don't really see anything else but the slides. Is that the way it's supposed to be?
Yes.
Okay, gotcha. Okay, so then let's introduce the next team of speakers. It's Professor Simon Murphy, as well as Dr. Rhiannon Evans. Dr. Murphy, or Professor Murphy, is a director of the DECIPHer, a UK CRC Centre of Public Health Excellence at the University of Cardiff. And he also leads the Health and Care Research Wales-funded Public Health Improvement Research Network and the School Health Research Network. Dr. Evans is a senior lecturer in social sciences and health based at DECIPHer, and as part of the senior management team, leads the program work on healthy social relationships. Welcome, and why don't you take it from here?
Thank you very much for the welcome. Myself and Rhiannon are going to present today. I'm going to sort of do the first part of it, and Rhiannon's going to end up focusing on some of the reflections around sort of transferability of what we've done in Wales. For those that aren't aware, Wales is part of the UK and has its own devolved government that's responsible for education and health. So for a relatively small nation, it has opportunities to think about how you can create a system within the country. And what we've been interested in with the School Health Research Network is how you can reorientate a education system towards health. So that what I'm going to be talking about today is a sort of system-based intervention. So if we could just start by thinking about the why did we want to set up this network? Well, for anyone that's involved in school-based health improvement or public health research, knows that there is a number of challenges to conducting research. So whilst schools are seen as key settings for health improvement because of their ability to have contact with a large proportion of the population at a significant period of their life and development, there's significant evidence showing that the research translation to policy and practice is a tricky one. Often it's not understood or used by schools, and even when it is, education and health are often seen as competing priorities. Conducting the research is also challenging, that there's increasing problems in terms of accessing school. To reduce the research burden on schools is something that we're all well aware of. And the other challenge in conducting research in schools is that there's a lack of routinely collected high quality data for both planning, monitoring and evaluation. And if you compare that to healthcare systems, for example, where you have those routine data sources, then again, that's a sort of another challenge for conducting research. So when we were looking at that, we thought that there might be successful models in other areas. So clinical research networks, for example, have successfully achieved system change and introduced routine data and more evidence-based practice within their systems. So we set up the network, and it had a number of aims. So next slide, please. So we wanted to develop an infrastructure which would develop capacity for evidence-informed prevention and translation. So it would be working with stakeholders, both at regional, national government, and also at the chalk face within schools to build capacity so that we could develop and implement the evidence with them. We also wanted to develop a framework for routine data to provide for both national, regional and local stakeholders. And through this, we wanted to co-produce high quality school-based health improvement research and reduce the burden on schools. And in doing that, create almost a continuous improvement system so that we would build in reflection and collaboration at all parts of the co-production and translation cycle. So we approach this very much thinking about the education system as a complex, adapted system. So in approaching this over the times we've implemented the network, we've developed an iterative model and framework, which I'll move on to next. And we've called this the Transdisciplinary Action Research for Complex Adaptive System Change, or TCAS for short. And it consists of a number of different elements where we've been able to understand and monitor our success in how we've addressed system change. And it begins really with establishing strategic partnerships, because such partnerships represent opportunities to disrupt the existing system. So part of this might relate to a strategic advisory board that we have for the network, but also parts of us as a network engaging with other advisory boards across the system and trying to promote policies that would link health in the education system. And we've done that reasonably successfully. To take advantage of these system disruption points, we need to build capacity of social agents in the system. So we've developed not only researchers that can go out and work with schools, but teachers that can work with us as researchers. And we've also tried to look at where there are data sources in the system and to link those up. The next part of the system change is trying to establish new social networks. So the social agents aren't enough in themselves. We need to actually build capacity and interactions across the system. So we've engaged in network development across the whole of Wales, having events and webinars and ways of sharing good practice within the network. The next phase of the model is to trying to imbue system self-regulation. So the successful co-production and activities that we do with schools and stakeholders, national and regional, sort of provides new habits and ways of working. And probably the most important part of this approach is identifying reciprocal benefits and outputs within the system. Because if people engage in these new ways of working, if they're aren't benefits for them, then the system will retreat to its original starting point. So we've really tried to focus on what are the things that are going to make people carry on working in this partnership way. So I'll just say a little bit about some of those elements next. So just in terms of the success of the network, we started this in 2013 with some pilot funding. And we used some existing resources in the system related to the Health, Behaviour and School Children Survey. This is a European-wide survey which is conducted every 4 years. So in 2013, we were going to be conducting the normal survey with Welsh Government, with 82 schools, and we recruited them or asked them to be part of the school network. And we got 61 of those. And in the next round of the development in 2015, we approached all of the schools in Wales and managed to recruit about 50% of them, 115 into the network at that point. And that gave us an idea of the sorts of resources and systems we'd need to have total diffusion, which we achieved in 2013. So we got every secondary school to be part of our network, and we recruited them with our Public Health Wales partners in the Welsh Network of Healthy Schools scheme. So now, whilst we rode on the coattails of the Health, Behaviour and School Children Survey, now we're able to support the Health, Behaviour and School Children Survey and embed it in the work that we do. Next slide, please. So one of the key planks of our network is the data infrastructure. And every other year we go to our schools in our network and we conduct a pupil level electronic survey and a school survey with senior management. So we collect data on the pupils, and these relate to some of the European measures from the HBSC, which cover the usual risk behaviours and health and wellbeing, mental health, school relationships, these sorts of things. And each round we work with our scientific collaborators, policy practice, and particularly the school pupils themselves to identify the priorities that they want to include in the survey. So to give a sense of how successful we've been with this, in our last data suite, we got about over 70% of all the pupils in Wales completing it. So that's over 120,000 responses, and it's the largest data set of its kind in Wales. And we also did a consent to linkage to routine education and health data, and we've established a longitudinal cohort which is self-replenishing every time we go back in. Next slide. So this is an example of the reciprocal outputs that we use with the data. So we provide school and regional level data for local health action planning. So this takes the form of reports which go to schools, and I'll say a little bit about this on the next slide. But we provide national indicators for Welsh Government, and this allows data on trends, health need planning, and international comparisons through the HBSC part of it. But we're also able to provide practice level data to support our public health partners. So this is the system improvement element of what we do. So we're able to analyse what's going on at the school level and link that to the pupil outcomes, and we can do that on an ongoing basis across schools over time. We've also got an infrastructure to support new studies, so we can help with recruitment and sampling, baseline and context data in much the way that you would have within a clinical research network. And we've got a current portfolio of £25 million and about 45 studies within it. But we also have an infrastructure to support natural experiments and policy monitoring, and we've done this for a range of policies with Welsh Government, our national government. And you can roll out new policies and evaluate them at low cost within an existing infrastructure. And these are all things which are generated by the pupil and school survey that we do. So next slide, please. This is an example of what schools get. So it's a student health and wellbeing report, and every school as part of our network will get a tailored benchmark report so they can see where their school sits, for example, in the mental health of their pupils, the experiences of bullying within their school, and they can use this for health action planning, use it with student voice groups, with parent governor groups, and then in 2 years' time, they can look at the impact of the actions they've implemented and see if it's made a difference. So we've been doing some work with schools recently, and they used our data to look at sugary drink consumption, for example, and they used it to remove the vending machines from the schools, and the following data sweep, their sugary drink consumption dropped by 50%, and also the comparisons to other schools was really good. So next slide, please. So these are an example of some of the papers which are produced by our team, which recognise continuous system improvement, and it looks at the relationship between what school practices are and the pupil outcomes. And next slide, please. This is an example of some of the network and capacity development we're engaged in: termly newsletters, webinars, research briefs, and networking events in North, South and West Wales. And we've also engaged in research literary workshops, professional development courses and placements. And we're also developing pupil engagement infrastructure to empower the pupils to take ownership of their data. Next slide. And this is just some examples of some of the social media accounts that schools have been tweeting with, just showing how the data is being used on an ongoing basis within the schools for real impact at the chalk face. So I'm just going to hand over to Rhiannon just to talk a little bit about the reflections and thinking about translation and adaptation.
Yeah, thank you, Simon. So I guess we had 3 key sets of reflections that we wanted to bring to you today, and would be keen to pick up in the discussion, but equally Simon and I would welcome exploring this with you outside today's session. So I think the first thing that we've really reflected on as a consequence of our experiences of SHRN is the importance of relationships and aligning those relationships within the policy context in which we work. So from the first point, we'll see that we've built partnership alignments within Wales that really link to key policy reforms and developments that we've seen. So we have a Future Generations Commissioner in Wales who really prioritises the well-being of young people, and then education inspectorates as well, and the recent report on healthy and happy students, really. So it's really about building alignment within the system with key stakeholders. I think the second point then linked to that is really that we have developed those relationships over a significant period of time. And actually, Simon started developing some of these relationships with a range of stakeholders in the 1990s. So it has been nearly 30 years of work to build to this. And we had interdisciplinary, interprofessional networks through what we call FERN, which is our Public Health Improvement Network, and then DECIPHer, which is the main research centre that we're working now, which was established in 2009. But also I think we can think about some of the learning points and reflections about the nature of evidence, really, and meeting the different needs of those diverse range of stakeholders that we work with. So centrally as academics, we're highly committed to high quality research, but recognise that impact can mean different things to different partners, and that there are some risks and compromise in trying to meet those different needs. So we have competing demands. The publication of the academic papers that Simon just mentioned can be difficult when we work in local and national policy cycles, where it can be pressing to disseminate evidence at a time that suits our various stakeholder partners. And then keeping a scientific coherence, particularly an overarching sort of methodological and substantive coherence to what it is that we do. But we've worked well, I think, through developing different communication strategies, and Simon has shown some of the outputs that we now produce as part of SHRN, and they are tailored to different audiences. And I think we would reflect as that being a really key part of our process in order to continue our relationships going. But the last point I wanted to think about, really, is one of the main reasons that I kind of wanted to attend today, is about the future of SHRN and these system level models that we might work within and towards. So we have this coherent model which is national within Wales, but we're now looking to see about moving the whole system into other contexts and other systems. So currently working with what's termed the SHINE network in Scotland. So trying to see, can we transfer SHINE into Scotland and create something which is similar, but that is its own unique context with its own challenges as well. Also working with WHO for a European pilot to roll it out more extensively across mainland Europe. And within that, we're doing quite significant methodological development. So myself and another colleague of ours at DECIPHer, Graham Moore, are currently in the process of completing methodological guidance funded by the Medical Research Council in the UK, which is looking at the adaptation of complex interventions for new context. So it's looking at how do we take the essence of something in a complex system and make it work and replicate its impacts or acceptability in new settings. And just really to flag up that Graham and I will be hosting a special interest group on August the 6th, which will look specifically around the adaptation guidance. So if you were interested in attending that, we could pick up some of the learning today and talk more specifically about SHIN, but also other types of interventions that we are currently exploring their adaptation and the contextual contingency of their effects. So I think that's good.
Wonderful. Thank you very much.
Thank you.
And now we have the third and last speaker in the symposium. Dr. Ulrike Bollmann is head of the International Cooperation and the Institute for Work and Health of the German Social Accident Insurance. And she's also a member of the editorial board of Safety Science, a member of the scientific community on education and competency development, the Training and Advisory Council of OSHA Africa, and member of the advisory board of the Erasmus Plus project RISKMAN. Welcome, Dr. Bollmann.
Thank you very much. Can you hear me? Hello?
I can hear you, Dr. Bollmann.
Okay, then I will start.
Okay, wonderful.
Okay, thank you. I was in doubt. Thank you very much, Hanno Petras, for inviting me to hold this speak today. Welcome to the other speakers and to the virtual audience. We don't know how many people are listening to us actually. It's an honor for me to introduce you briefly into the development of the concept of culture of prevention in a totally different context, in the context of occupational safety and health in the work context, and with an international dimension. The next two slides, please. My presentation consists of two parts. In part one, I will introduce briefly into the concept of culture of prevention within a work context, and then I will switch to the development of leading indicators for a culture of prevention. Next, please. Some from the editorial committee asked me, prevention for what? And I got aware of the fact that the work context, the context of occupational safety and health, may be very different from the public health context. I brought 4 examples with me. One example, a factory. When we are preventing accidents at work, this could be an accident in a car factory where a human being collaborates with a robot. Or we are preventing, for example, musculoskeletal diseases of a teacher, or occupational mental disease from caused by the school environment, or mental diseases and musculoskeletal diseases of staff in a service center. At the moment, we are in face of COVID-19, and there is the problem of preventing health-related hazards, especially in hospitals. That would be a fourth example for what's prevention about in a work context. Next slide, please. Today, risks are getting more complex, and especially risks are connected to each other. For example, technology risks, economics crisis and risks due to globalization and migration, and last but not least, we mentioned it already, COVID-19 as a new powerful risk we are in face of. Next slide, please. And especially exactly this issue of complexity has been the start of thinking about culture within the context of work. It was the disaster, the atomic disaster at Chernobyl, when experts and practitioners recognized that the concepts on safety they have used before did not work anymore to explain the complexity of such a nuclear disaster like Chernobyl. Therefore, one concept at the start of thinking about culture was this concept of safety culture. It's quite research oriented. Another concept is the concept of Vision Zero. It's much more older. It started from the beginning of the 19th century, but we have a renaissance at the moment, more as a policy strategy of Vision Zero, especially in the international context, but also at national level. Next slide, please. How to describe this cultural shift regarding a culture of prevention in a work context? We would say it's more or less a change in perspective. The focus is no longer mainly on formal rules or, for example, legislation. It's more on informal rules. The wisdom of practitioners, implicit knowledge is getting more and more important for occupational safety and health. We are moving from a focus on physical factors to looking more for psychosocial factors. There is less an orientation on deficits, more on health protecting factors and resources. We are not only focusing anymore on behavior and attitudes, but we are more interested in how collective processes of sense making of safety and health are going on. And very important, because occupational safety and health is mostly work related, but now we are getting increasingly interested in non-work related factors. Next slide, please. How to describe a culture of prevention? What's the meaning of a culture of prevention at work? Common sense at the moment is that it means safety and health and well-being at work are integrated into all activities of an organization. And by this, they become a self-evident, lived-out part of professional and daily life. Next slide, please. The core model behind this understanding of culture of prevention within a work context is the organizational culture model of Edgar Schein. It's a multi-level model. He differentiates between the level of artifacts that can be guidelines within a company, that can be special products, the level of values. They are explicit as well, but still negotiable. For example, what's fairness? What's freedom? And then in the core of the cultural concept, the basic assumptions. They are more implicit. People are often not fully aware of them, and sometimes you are not able to verbalize them completely. Next slide, please. I would like to sum up. The focus of a culture of prevention at work concept is on collective process of making sense of safety, health, and well-being, the design of social relationships in a certain context, and, as mentioned before, the implicit level, consisting of basic assumptions that may be a biographical or cultural habitus, and its influence on the meaning given to safety, health, and well-being. Next slide, please. The second part of my presentation refers to the development of indicators of how to promote a culture of prevention, how to develop it. In our project, we differentiated between lagging indicators and leading indicators. Lagging indicators look into the past. They are more or less based on accident and disease statistics, and they show what is missing. Leading indicators look more into the future. They promise, I would say, you are sure they predict, but I would say they promise to lead the process to make safety, health, and well-being this natural part of work and private life. And they are looking for the positive. Next slide, please. In our project, Leading Indicators for a Culture of Prevention, we have had two parts. There was carried out a pre-study carried out by IOSH. It's a worldwide present institution for OSH practitioners. They did a literature review and a first survey. And then we were asked to continue and finalize the work of IOSH, and we set up a German-Korean project conducted by the two main organizations in the area of occupational safety and health in Germany and Korea. Next slide, please. Our German-Korean project covered a literature study, but with a focus on culture of prevention at work. We developed criteria how to select such indicators. We developed a multi-level model, conducted an international expert workshop, and finally, we developed 5 core categories, 17 leading indicators, and 47 sub-indicators. Next slide. Here you can see the criteria. We developed a people-oriented focus of prevention is on people and their capabilities, culture-oriented, not so much anymore the technical or risk-oriented view, but how to design social relationships. Processes are more important than outcomes. Interested in how people are thinking and acting, what makes safety and health and well-being meaningful, and concentrating on what goes well in daily work and not on what is lacking, and finally promoting change. Next slide, please. We developed a multi-level model that is based on Shine's organizational culture model, but the special thing with this model was that we didn't stop by covering the individual, group, or organizational level. Prevention culture concept in our sense covers also society and the international level, because the aim of this international project was to have, in the end, based on the national cultures of prevention, a global culture of prevention. Next slide. We developed 5 core categories: leadership, participation, communication, trust, and learning process. The first 3 ones are valid predictors for the development of a culture of prevention based on the research in the pre-study and on a scoping review conducted by our organization. Trust as the foundation, the very basic foundation for a culture of prevention, was the 4th category in the pre-study, and we are currently conducting a follow-up study on this, on leading indicators for the category trust. Learning process is the prerequisite for change, and we included it again in this framework. Going back to Fleming, who did, I think, the first list of indicators in the past for safety culture, and we adopted it for culture of prevention. Next slide, please. Here you can see the overview, our 5 core categories and the 17 leading indicators. I would like to highlight only a few. The visible commitment of leaders in an organization are essential for the development of a culture of prevention, and especially the style of leadership, for example, transformative leadership. We need true participation. That means to include people, to let them participate very early in decision processes, developments within an organization, to have a 2-way communication characterized by mutual feedback and dialogue, Then trust. Do you trust your colleagues? Do you trust your organization? That means interpersonal and institutional trust. And last but not least, safety competence and health competence. Safety competence to focus on the ability to cope with ambiguity, to focus with things that are not sure, that are unsecure. And the health competence. Are you really aware of your own health condition? How do you deal with your own health? Next slide, please. And that's my final one. What are the implications from our project for safety science and prevention science? There's on the one hand a shift from a deficit-oriented model to a promotional model, may be easier for public health people. There is a broadening of the perspective to more the organizational level, above and beyond individual level factors that may be more a challenge for public health. And if we all in occupational safety and health and public health would like really to develop a culture of prevention, then we need interdisciplinary cooperation and networking between safety science and prevention science. Thank you very much. Last slide. That are only my contact data. And as far as this is not published, I added my some of the literature behind to give you a good scope of the literature, especially in safety science, behind of this discussion about the concept of a culture of prevention in a work context. Thank you very much.
Wonderful. Thank you so much. Okay, so we have a couple minutes for questions. I hope you all heard the virtual applause for your presentations. Very, very nicely done. Really appreciate it.
No.
No, didn't you?
What a pity.
So two questions. We have two questions. One, I think that's for Bosco. Puzzling male-female coefficient, but think DECIPHer. Should risk factor be in model for age and sex, and which are time invariant at birth?
So just repeat that, please, Hanno.
So it's puzzling male-female coefficient. Should risk factor be in model? So I guess the question is, should age and sex be considered a risk factor and not a risk indicator, since they're strictly speaking not malleable?
I suppose I'm not sure I'm going to answer this question sufficiently, but I'll answer it in the way I think I can. So they were, in some ways, what we're looking at is we're looking at the clustering of what the literature shows is problem behavior. And so we did the latent construct for those variables. And then we looked at those other social demographic variables as predictors for those constructs. So I'm not sure if that's answered the question, but that was the rationale behind it.
I guess the alternative could be to run it as a multiple group model, for example, to kind of see if there are gender differences, because maybe throwing males and females together creates a little bit noise.
Yeah, it's a possibility that could be done. I suppose there is space there's limited space within a publication to do,
of course,
that type of thing, and I'm always unsure about how many multi-group analyses to do in these latent variable models. So yes, I'm sure that should be considered. This is really the first longitudinal cross-national study that's been done on problem behavior. So I think there's a lot to be done, but certainly we'll be looking into those suggestions.
Thank you. Professor Murphy, I have a question for you, and actually for you, Dr. Evans. In the US context, we know that schools really differ or vary widely in terms of their readiness to engage in innovative processes, both in terms of their general capacity and their kind of their innovation specific capacity, and those schools probably at the greatest need have the least resources, the least qualified teachers, the highest staff turnover, and so on. What does this look like in the Welsh context, and was that an issue at all? Because I mean, it's a very very stellar project. What you're proposing, what you're introducing to these schools, and
yeah, I'll kick off, and Rhiannon might want to add something. Interestingly, we've looked at some of those sort of school level factors and their relationship to pupil outcomes. And the more deprived schools actually have more sophisticated and more well-developed structures for student support. So where we've found the most sort of damaging effect is when pupils from poorer backgrounds go to a more wealthy school, because they're less geared up to cope. The other thing that's interesting is that the relationship between leadership and senior management and the health activities of school seems significant. So it's similar to what Ulrike said, that if there is leadership and visible leadership for that responsibility, it makes a difference.
Mm-hmm. Mm-hmm. It's interesting. Okay. I think this question is for Dr. Bollmann. And it's kind of, it's about looking at meaning making, and this person asked if anyone has done any qualitative research around how people make meaning of prevention at work. Mm-hmm. It's kind of this symbolic interactionism idea that
yes,
you
I think
kind
so.
of create that, yeah. Mm-hmm.
Yes. I know about Helen Bound. She is, because it's a little bit special. There is a social constructive approach, and I think they are working in the area of sociology. The philosophical approach via Husserl or Merleau-Ponty does not arrive in the area of prevention. That's a little bit a problem. There's a big gap between the theoretical concepts and the area of prevention from my perspective. But I would mention two people. Helen Bound from the University of Singapore. She is working in this field of sense making of safety and health in a work context, and she is more or less working on a social constructive approach, and is using research from an anthropological point of view. And Frank Guldenmund, she is one of the heroes of the safety culture scene. He's from the University of Delft, and he is a big thinker. Therefore, it's possible to address him for this sense making issue as well.
Mm-hmm. Okay, great. Thank you. There's another question just came up for Bosco. Did you use cut points to identify students at risk? If so, did you use the same cut points in all of the countries?
Yes, we did use cut points, and the cut points that were identified in the literature for the risk factors. And I can't remember, but I'm pretty confident that all the same cut points were used for the countries.
Mm-hmm. Okay, great. I had a question for both Dr. Bollmann and Professor Murphy and Dr. Evans, and that is kind of the question, how do you introduce innovation? And you spoke to both that you need to have the involvement of the management team, the leadership, to have them serve as champions. But we've also seen in prevention science that there is a bottom push to be innovative, both in labor safety, but probably also from parents and students in schools. But at the same time, and I think Professor Murphy, you mentioned that in order to get in, it's nothing easier than to get kicked out of a school or a community. And so you have to ensure the buy-in from those who can make the decisions. But do you see the relationship and from the that there's this grassroots push for innovation and change?
Well, I think one of the key constituents that we see here is the young people and people themselves. We take very much a sort of children's rights approach to the research we're doing. So we see them as active participants in the data being theirs to do with what they want to do.
Mm-hmm.
And young people today are used to those sort of dealing with data and information. So again, that could be a real push for system change, I think.
Mm-hmm. Great. Well, I think our time is up. Usually we have 30 more minutes, but we're constrained to 60 minutes. Well, let me thank you again for 3 great presentations, and I hope that we can continue the dialogue on the culture of prevention, and that kind of our initial thinking represented in the special issue in prevention science will resonate with folks. And we're not pretending to have all of the answers, and but I think that if we can engage in the discourse and what this means, and I think during the pandemic, it has become even more important that we need to start thinking about a culture of prevention, not only nationally, but internationally, given how connected everything is. And with that, I'd like to thank the presenters for their excellent presentations, and also the virtual attendees of the session. I don't know how many there were. And I wish you a great rest of your day, and please stay well.